Sabrina, oh, and then we need someone to discuss this. This is kind of an interesting one. You want to do I guess the most senior we have is Heidi. You want to do this one?
It's out.
Oh, yeah, I'll take it. Sure.
Well, no, you're presenting.
Okay. Off the hook.
Yeah, somebody's not presenting.
I think.
Yeah, okay, Heidi's gonna discuss it.
Yeah, thank you.
Okay, good morning, everybody.
Hi,
Sorry,
Gloria.
the date is wrong. I was gonna present last time and it didn't happen, so I have to change it. Sorry about that. But sorry, I'm not there with you guys. But okay, so 53-year-old female. She comes in, she says 2 weeks ago, she woke up with blurred vision in her left eye. She usually gets up around 5 a.m. and then she noticed a gray spot in the left eye that didn't go away. Both of these vision changes in her eyes are new for her. The gray spot is not getting any better or worse in the left eye. For her systemic meds, she's on lisinopril, metformin, nifedipine. Her vision is 20/80 on the right, and it pinholes to 20/50, and then near vision is J10. Her left eye vision is 2200, and she pinholes to about 2400. Her pressures are normal in both eyes, and then there are no AC or vitreous cells.
Okay, so
Alright.
color. Can you guys hear me in the
Yeah.
virtual world? Okay, so color fundus photo of the right eye. So the media looks clear. The nerve looks pink, sharp, flat, maybe a bit tilted. The vessels look a bit tortuous. The macula from this angle looks okay. Looks dry, flat. I don't appreciate like any deposit, no deposits, drusen. And then superiorly to the nerve,
You can point this, but they can't see it. She's gonna point here, but you guys won't see it, but you can use your imagination.
and superiorly up here, not sure if
perfect.
that's artifact.
They have this connection.
Little whitening area there, and then possibly a hemorrhage up there.
Yeah, and actually there are a few little baby hemorrhages kind of around. They're hard to see without it more zoomed in, but can you guys see my mouse or no?
Yes.
Yeah.
Oh, you can. Okay, yeah. So there are a couple like little MA, tiny dots there. There might be like a little blot there, like an MA there. And then yeah, this mostly looks like artifact here. And then maybe there's some bias in my perception of the nerve because I know the case, but there might be some blurring of the disc margin, especially at this border. And then I'll go to the next one.
Ooh. Yeah, I think that line on top is an artifact. That sort of hazy, I'll put it over right there. That horizontal line. Yeah, I think that is an artifact in the camera you get sometimes.
So color fundus photo of the left eye, attention's drawn to the optic nerve. The margins are blurred. There's a hemorrhage at the superior disc margin. It looks elevated and edematous. Otherwise, that similar spot there, or you're saying that's artifact?
No, the one, what spot's now, I think.
Yeah,
The one
that dinsel's real.
Yeah,
Okay.
you go with that.
Yeah. And then maybe some MAs here. And nothing too significant in the macula.
I don't know if these are exudates or not. I forget what the other photos look like, but they might be. I can't remember. But yeah, agreed.
So OCT, I believe of the right eye. Foveal contour is normal. The outer retinal layers look pretty intact. Maybe just the quality of the image. I can't really make out too much of the outer retinal layers here. No fluid. Vitreous looks clear. Choroid looks appropriate thickness.
Yeah, how old was the patient?
53.
Because it is a little tiny bit lumpy. Just a
Yeah,
smidge.
especially here.
Yeah, just a tiny little bit for 50, maybe. I have to say, I had a case like this that I missed. and the lumpiness was of some importance.
Is that,
lumpier than we'd
could you
like.
attribute that to just like the quality of the image? Is that what
Not
you
the
mean?
lumps.
No.
Lumps is their
Is it-
age. I mean, there would be drusen, could be drusen.
If you
Oh.
follow this white band, you can see it kind of breaks apart there. I think that's the PR layer and then RPE brux underneath it. So there is some, I think you would call it RPE nodularity there. Okay, cool.
OCT of the left eye. Or no, sorry, are we still doing the right eye?
Yeah,
Mhm.
Still right eye. Yeah, possibly something there, parafoveally,
probably a vessel.
I guess demonstrating similar things, and then I think that's just the best way to.
You don't want to go crazy. Those lumps on the last one were pretty minimal, but they might be something, but they might not. You know, because like I always tell people, you look at your hand long enough, you start seeing all these spots and stuff. And, you know, eventually drive yourself crazy.
Okay, so now we're doing I believe the left eye. So this looks like there's some elevation here, towards the nerve. Foveal contours and path, and then possibly some hyper reflective spots here and, in the center of the retina. A little bit of disorganization here, outer retinal layers. And then is that a fluid cyst? I'm not sure, I can make it out there.
It does, yeah, it does kind of look like one. Yeah.
Mhm.
And then these probably correspond with the yellow spots we saw in the fundus photo.
Okay. So back to the right eye.
This
Vertical.
I think is a vertical of the left eye.
Okay. So similar findings, maybe just this one hyperreflective spot there that's,
Mhm.
and I think it's the photoreceptor ISO junction there, a little disruption there with some migration. Pigment migration. Okay, so the thick central macular thickness, can't really see it from here, but it's a 283.
263.
Wow, I didn't.
The fraction, yeah.
See that.
And then I think 256. Okay,
Mhm.
so pretty normal macular thickness. Now you're killing me here. They look green.
Sorry.
from here.
They're green. On the right side though, it's the global is 100. On the left, it's like 243 or 248 or something like that.
Okay, yeah, so just highlighting the optic nerve head swelling. All right, so FA of the right eye. This might be the AV thing.
Yeah, because you have arterial filling there. We'll flick through a few, and the reason this starts late is clinically the left eye looks worse, so we use that as our primary eye. But I'll kind of flick through and then we'll go back. So sorry, that's the beginning again, and then
Some spots here that are hyper reflective.
you would say fluorescent, but yeah.
Hyperfluorescent, these spots as well, I think corresponding to where the MAs were.
Mhm.
And then the area of hypo reflectance or fluorescence, excuse me, there. That was the area that was white that we saw in the color fundus photo.
And sorry to be spacey, but is this patient diabetic?
She is.
Okay.
And then for the white spots that you said may correspond with the MA, what type of hyperfluorescence would you call that for these little ones?
Staining,
Is it-
cooling, leaking, or
Possibly staining or pooling?
What's the difference between the three?
There's five.
So leakage is when there's like blurring of the margins.
Window.
What? Oh, window defect?
Awesome.
Oh, okay. Okay, sorry, whatever.
So are they getting brighter with time?
The MAs, I don't believe so.
No, the white spots and the,
Oh, these areas?
yeah.
Do you mind scrolling through it again, Sabrina?
Mhm.
A little bit.
Well defined, or are they?
No, not
That's
super
not
well
blurred
defined,
margins.
blurred margins, when I do pooling. Or
Which
leakage.
spots are you talking about?
I guess the ones here in the macula.
I think you're talking about the microaneurysm, they're talking about the white smudgy spots.
So,
So
Oh,
the
okay.
microaneurysms become brighter, but the borders stay the same. Yeah, and then the other spots, the borders kind of smudge out, right? So if the smudgy border ones, what would that be?
Leakage.
right, in
And
general,
the
in general,
non-smudgy borders would be cooling. We don't usually say that.
yeah,
for
in
microaneurysms.
general, this is leaking more or less. I wouldn't split too many hairs with this one.
And what about the nerve? Did you talk about the nerve yet?
The nerve,
Right, or normal or abnormal?
it looks pretty abnormal.
What's abnormal about it?
The areas here are blurred.
Good,
So
bright, too dark, or just right, like porridge?
Uh, well, it's usually supposed to stain, right?
But
Not
yeah,
much.
not much,
It
no.
actually, it can
Yeah.
stay pretty dark.
Yeah.
I'll show you some cases of kids. I've been getting kids for pseudopapilledema versus papilledema. The FA is apparently the most sensitive, so I'm getting all these kids like that.
But you
But
got,
it
but you
should
got
stay
it.
dark.
It's a little too bright. It's a little too leaky.
Yeah.
A lot too leaky.
So even though the OCT was normal for nerve fiber thickness, there still probably is a little nerve issue here, maybe. And for diabetic,
Then. Okay, so some areas of leakage. Kind of in the macula superiorly, and then this is in this area of, I guess, either blockage there, some leakiness at the nerve. That's the right eye. Left eye, this is the, we said startle autofluorescence. And, super
I'm gonna-
hypo. Okay. Oh,
I'm
sorry.
gonna
this is
flick
a-
through a spot.
so what phase is that first one?
This is the arterial,
Good.
Mhm.
Okay.
Mhm.
and the, AV phase, which
Yeah.
we starting
Well, laminar. We
laminar.
sometimes say laminar. Laminar.
And then you can kind of see the laminar there, and then this AV phase.
But this might be a good cut of the nerve for now to talk about some of this stuff here. How would you
So,
describe that?
Areas of blockage where the heme was.
Perfect.
You
And
tell
then
the
now
level,
here.
Sorry, where's?
the level of the retina for the hemorrhage. It's kind of interesting. The vessels, does it obscure the vessels, go in front of them or behind them or anything?
Some areas it's obscuring the vessels like over here.
Yeah, okay, good.
And then MAs here.
Is there non-perfusion? It's a diabetic.
Maybe a little bit up here. I can't tell if it's like the
Hard to
artifact.
tell, but there is not.
There's not, yeah.
Okay.
Yeah, we gotta get used to it. For peripheral retina, when you see a peripheral retina, you're mostly just looking for non-perfusion.
Mhm.
There's other stuff, but there's not non-perfusion.
So more leakage here, some blocking, and then MAs.
And don't call it blocking till the end. What you want to say on your boards, plus it gives you time to think. You want to say hypofluorescence associated with the optic nerve corresponding to the hemorrhage on the color photo.
Okay.
Just
pigeon.
by yourself all the time you can. Just describe what you see till the very end. Otherwise, you might dig yourself a hole that then you have to dig out of.
Okay.
I think that was it for the FA findings. Was there anything else anyone wanted to point out? All right, cool. So to summarize everything,
Oh, so to summarize, so we have I forgot her age, but a female, like 50-something female that presented with, sudden vision loss, I believe centrally in the left eye it was.
and blurred vision on the right too, so both eyes.
Both eyes. She woke up with it. And on imaging, we saw blurred margins of the optic nerve. It was right greater than left, or left greater than right. With associated hemorrhages at the disc, and then some maybe non-specific like diabetic changes.
What would be your differential and what might you want to do if this lady came into the ER?
So the bilateral nature, I'd want to, rule out increased intracranial pressure. I'd want to get possibly, neuroimaging, MRI, brain, orbits, possibly an LP.
What blood
Do
work
you have
would
in
you
your
get?
head do you have in your head a just general differential for swollen optic nerves? You guys can kind of chip in if you want.
So Heidi mentioned like increased ICP, so since it's bilateral, if there's a compressive lesion, if there is probably not pseudotumor in this like 50-something-year-old, but that's one of them.
It's Tampa,
Like a
so syphilis.
syphilitic nutritional deficiency.
I have four I kind of run through. So in my head, I have four general ones, and then there's all the weird ones. So my four are increased intracranial pressure, optic neuritis, ischemic, or dystrophy. But there's other stuff too. So those are kind of the four, and you can and then there's questions. So once you get it in your head, you start asking questions. So do you have pain on eye movement? Right? Because 95% of people with optic neuritis have pain on eye movement. Also, if you look at the optic neuritis treatment trial, nobody had disc hemorrhages, which is kind of an interesting little thing. So, which I know I heard that at a meeting once. I didn't actually read it, but it's kind of a cool little fact. So if you're looking at optic neuritis, a disc hemorrhage, probably not. For ischemic, is the vision, and then is the vision good? So in disc edema and in pseudotumor or papilledema, usually the vision's good. So is the vision's good? Is it both eyes? And then for ischemic, is the vision bad? Is it one eye? Is there hemorrhage? And then for dystrusion, you can get your autofluorescence and stuff if it's in adults. So those are my four. And then you have the other ones. So, but the four, like 99% of your discs are going to be one of those four, and you can kind of roll through it and just ask certain questions and narrow it down.
So which one does this narrow down to?
That's really it. But that's my general nerve thing. So you guys were good though. Everything you said was good. But that's sort of an organized way. I was thinking of four things for the nerve, then a question for each one, and then like, okay, here's where we are. And then if it doesn't quite fit those, then you got to go into the other things.
So less likely the optic neuritis, given the hemorrhage. Still, optic differentials probably increased ICP. I'd want to rule out promptly.
Usually the vision's pretty good with increased ICP. So I don't know that I put that so far up. And then ischemic, it looks kind of ischemic, it's hemorrhagic and all that. But then you've got your infiltrate. I mean, then there are a bunch, then you got your infiltrative, your vitamin, your inflammatory, infectious, inflammatory and all that. So in this case, since it doesn't quite hit any of them that well, she's diabetic, which kind of screws it up some. You got to go down a larger differential, I think.
There was an old diagnosis called diabetic papillopathy, which is not classic for, but it's related to ischemic and to ischemic optic neuropathy, I think.
It's a weird one. And traditionally, they were supposed to do better, right? Typical. So it was weird. Ischemic optic neuropathy typically had vision loss. Diabetic, it's like a sixth nerve. There's something about these six nerves and diabetics, like don't worry about it. Six nerves and non-diabetics, you get all freaked out. So there's something about them where they seem to have these insults, but then they get better, which is, I don't know.
And wasn't there one called it's like hypertensive, they call it papillitis?
Yes,
It's not actually inflammation.
Right.
Yeah, right. And this could be hypertensive too, so you gotta make
Check
sure.
the blood
What's the
pressure,
blood
yeah.
pressure?
Yeah, blood pressure.
Because that can be bilateral and that can have
And
hemorrhages.
hemorrhagic with vision loss. And then the other findings too, she had some other spots in the retina. All right, so Sabrina, go ahead, you take it over.
Okay, so this patient had labs done. She returned 3 weeks later. Her vision in the left eye was worse. It was 20. Oh, actually, no, sorry. Both of these were better. 2032 on the right and 2200 on the left. Heidi, I'll have you take it away again.
Okay, so color fundus one of the right eye, kind of highlighting similar, maybe a little bit worse of the blurred margins of the optic nerve.
Perfect. And then here.
Left eye, maybe a little bit of improvement in the hemorrhage, and then
Yeah.
the blurring of the margins.
And then there's some pallor here now too.
Yeah.
It's her OCT.
So OCT right eye, I see some vitreous opacities, quite a few of them. And then again, that kind of nodularity of the outer retinal layers subfoveally. This is the left eye. Left eye OCT, similar vitreous opacities. And again, the same, area of the outer retinal layer changes right there. Yeah.
Are we gonna get her extensive lab workup, or is that the answer?
My syphilis. is going
It's
back.
the answer. And I don't know if this is just the
Getting
cut of the
weirder, so it's getting
OCT.
more complicated.
But the foveal contour is a little attenuated on the side too.
Oh, yeah, that's
Um,
off, that's just off center.
It's just off center. Oh, okay. Oh, okay. And then I'll read these to you since they're tiny, but these are both the right eye. And I don't remember the top day. I think it was like the beginning of April. It's blocked for me by the. Okay, perfect. And then it's 103 or something, and then she's 171 on April 21st. This is the left eye, it's 240, and then 130 as the two. So we kind of talked about the findings. Web said syphilis so early, so good job, Web. So her titer was 1:32. And her FTA antibody was reactive.
Bartonella, syphilitic lady
Yeah,
who likes,
Bartonella.
who likes cats.
Ooh, yeah.
Ooh. Dr. Pavin used to say that he has a solution for all the cat-borne illnesses, and it involved a cinder block and a burlap bag.
What do you make of the Quintana also being positive? Could that be cross-reactivity or a false positive for the Hensley?
Oh, gosh, you probably know more than me.
Because the infectious disease docs now get that, and then if the Quintana is also positive, they say, well, maybe this is cross-reactivity.
Yeah, it probably is.
Because that's what's more like syphilis, like there's no macular scar, it's bilateral.
Right, and those
It's
are
a cat scratch,
IgGs, right,
he's in the wrong age group,
and her vision's not getting better.
and it's not getting better.
And so you would treat things in order, right? You would treat the syphilis first because it's a more serious diagnosis, and the Bartonellas, they're kind of self-limited.
They are self-limited. Yeah, I mean, I'll give someone some doxy.
Right.
And I think it's
And it will
soon
treat
enough
the
after
syphilis a
the
little bit
event.
too.
Yeah, the IgM, your IgM's positive for 3 months?
I'm not sure.
You guys are just at a med school. I think it's 3 months, somewhere around the two, but I think she was still like, with the acute episode, I think her IgM should still be positive.
Mhm.
So the negative IgM means I think it's just a nothing.
And I think that nodularity, the outer retinal layer, you can see that with syphilis.
Yeah, with
It's
syphilis.
like,
Yeah, I had a patient where I had a patient with uveitis and I coded him as macular degeneration. He was an African American, it should have been a red flag, and then I got a lapse back and it was syphilis. I was like, I should.
The thing
then
that made me suspicious were when the cells all appear in the
Yeah.
OCT after having. Otherwise, I was thinking, chubby diabetic needs to go cycling. Blood pressure is probably 200 over 100. We forgot to check it. But then when you start seeing inflammation, like florid inflammation, then it changes the entire timbre of the case to something more inflammatory or infectious.
Yeah.
Okay, I think if you go back to the early FAs, it does give you some signs that there is an inflammatory process going on. You kind of get like these patchy, it just kind of leaks a little bit.
Oh, in the right eye. Yeah, show that late one in the right eye, the other eye. Yeah, that
Yeah,
looks like
that looks
uveitis.
inflammatory
That's
to
when I
me.
The
see
nerve
that,
looks
yeah.
a little hot.
Yeah, when I see that, like either pseudophakic CME or uveitis or
Yeah.
something. Yeah, I think I agree. That's sort of like
But
an
yeah,
uveitic.
in diabetics, you can get inflammatory looking FAs. I
Right.
agree, this is a
Mhm.
little more inflammatory looking than you would expect in a diabetic, but
Yeah, that's why the odds are good.
yeah.
What do you make of that original hypopigmented spot on the color fundus photo, superior to the nerve?
Well, she's diabetic. I think some of that, it might have been syphilitic or uveitic, but it could also just be condymal spot.
Yeah.
I think, if that's the same one.
Most of the time when they come into the ER, they have the uveitis or a swollen nerve, like the posterior placoid. We get a lot of that too, but I don't think that's the most common.
I know, well, she's gonna talk, so go ahead, Sabrina, what you got?
So she was hospitalized with IV penicillin treatment. She was actually just seen on the 25th, and her vision was 20/80 and 2200 after treatment. So
Dr. Tucker have the opportunity to make the diagnosis. He loves diagnosis.
No, this is ours.
This is our patient. Okay.
My dad always says, tell them they have Lew's disease and they have spirit A's in their blood. Sounds better to me.
They'll be excited.
So, go ahead, Sabrina. Keep going.
So there's still a little bit of pinkness to the nerve there, but there's a lot of pallor on the temporal side for the right eye, and then same for the left eye. There's a lot of temporal pallor there too. And then just showing you the RNFLs and the progression of them. So from 100 at her first presentation the first week of April to 171 to 194 and then 62. So it's atrophied by this point. And then same for the left eye, 249, 139, 80, and 59. So the final diagnosis is syphilitic optic neuropathy, and we'll talk about some of the other findings too. And we talk about syphilis a lot, so I'm just going to keep it broad and quick. But syphilis is caused by the spirochete Treponema pallidum, and it is transmitted by sexual contact.
White, vaccine, hospital-wide, code white, vaccine.
You gotta look at your card.
There are at least 12 million new cases each year, and the rates had steadily dropped until about the year 2000. And then a rise in the incidence occurred. In the US, most cases occur in the South and the Northeast. HIV co-infection is an important risk factor for syphilitic infection of the eye. And then as far as syphilitic optic neuropathy goes, so ocular involvement can occur in any stage, but syphilitic optic neuropathy occurs as part of secondary and tertiary disease. It's not that common. It represents about 20% of all cases of ocular syphilis, and it's even less common to have isolated optic neuritis. Usually there is some sort of associated anterior or posterior uveitis. Most cases are unilateral, but it can be bilateral. And as far as symptoms and signs go, so patients come in with blurred vision or scotomas, and then for signs, decreased vision, color vision, and an RAPD are usually present. In anterior optic neuritis, you also have you'd have the disc edema or hyperemia, plus or minus some inflammation in the posterior vitreous. And posterior optic neuritis, the optic disc can actually appear normal. So you might have like decreased vision, decreased color vision, and RAPD, and you look and the nerve looks fine. That might be consistent with like a posterior optic neuritis. And then in perineuritis, the patient has a constricted visual field but good central vision. Some ancillary studies you might get is a field, and that might show a central scotoma or an enlarged blind spot. And then for making the diagnosis, you have your non-treponemal tests, the RPR and VDRL, and the treponemal ones are the FDA. The lumbar puncture can be used to look for VDRL and FDA. You'll also see an elevated protein, leukocytosis with a mononuclear predominance and normal glucose. And as we know, a negative CSF study doesn't rule out neurosyphilis. You treat with 18 to 24 million units of penicillin for 10 to 14 days. Some papers discuss using steroids as an adjunct for cases where the patient comes in with pretty severe vision loss. This is given only after a week of the antibiotics are administered. And in some of the studies, they did IV methylpred 1 gram daily for 3 days, followed by 1 mg per kg of pio-prednisone for 2 weeks, then rapid slightly tapered. So as far as the prognosis goes, usually it's pretty good with syphilis, but a poor prognosis is associated with time between onset and treatment being greater than 12 weeks, or duration of ocular symptoms being greater than 28 days, the presence of macular edema or long-standing optic neuropathy, co-infection with HIV, and then poor initial visual acuity. So in this lady, I think when she had initially came in, and there may have been a spurt where she didn't come to her follow-up appointment, but there was maybe a little bit of a time before she waited to come in with her symptoms.
No,
And I don't know.
might be diabetes too, I wonder, because she really did have a crummy outcome, and syphilis usually doesn't. I wonder if the ischemic from the diabetes maybe did her in a little bit.
Okay, yeah, maybe. Yeah, because we have had several other cases of syphilis in case conference where the vision is typically dramatically improved from like 2200 all the way back down to 2020, 2025 or something. So yeah, I don't know if it was just because she had so much nerve inflammation or if there was something else going on that resulted in her optic neuropathy. But that's all I have for you.